My name is Teresa Prosser. I'm a primary care practitioner, board certified in pharmacotherapy, a certified asthma educator, and a professor at the St. Louis College of Pharmacy. My topic today is current and emerging strategies in the treatment of chronic obstructive pulmonary disease. I do not have any conflicts of interest to disclose. I'm not on any speaker bureaus for any pharmaceutical companies. I have no financial interest in, nor have I received any recent grant funding from such sources. The information I will present today is consistent with the published national COPD guidelines, that is GOLD 2011, and also the ACP guidelines, also published in 2011. The ACP guidelines are a joint production from the ACP, the American College of Chest Physicians, the American Thoracic Society, and the European Respiratory Society. However, as I will note during the presentation, not all of the medication classes recommended in the guidelines actually have an FDA-approved indication for COPD. Here's an outline of our discussion today. We'll start with the current trends and statistics, review the GOLD definition of COPD and its risk factors, briefly discuss the diagnosis and assessment of COPD. We'll discuss our current understanding of the pathophysiology of COPD and how that relates to comorbidities. We'll focus primarily on the outpatient management of COPD, primarily stable COPD. We'll discuss key patient educational issues and treatment of exacerbations. COPD is a serious health issue in our country. In mortality, COPD passed stroke to become the third leading cause of death in the United States in 2008. Granted, it's somewhat of a distant third to heart disease and cancer, so that while heart disease and cancer were responsible for about 600,000 deaths per year each, COPD is still responsible for about 140,000 deaths per year. Importantly, however, while heart disease and cancer are continuing to decline at about 2 to 3% per year, COPD continues to increase, rising about 1.2% between 2010 and 2011. These data may actually underestimate the true impact of COPD, first due to the underdiagnosis of COPD, and secondly that cardiovascular disease is a frequent comorbidity, and so the actual listed cause of death in a patient with COPD may be listed as cardiovascular disease. COPD is a major cause of tobacco-related deaths. Cancer, cardiovascular disease, and COPD are the top three in that order, but they're all close to about 30% or slightly more. COPD is also a significant source of morbidity in this country. In the latest data from 2005, it's currently listed as the fourth leading cause of disability, so about 2% of all of those who are disabled have COPD. The top three being arthritis, back problems, cardiovascular disease, and then COPD is tied with emotional and psychiatric problems for fourth place. Of those with COPD, about 23% of individuals limit their activity due to the disease. And for every 100,000 individuals with COPD annually, there's over 500 hospitalizations and close to 800 urgent care visits. Another reason that we're restarting again. Another reason that COPD is a significant health issue are its costs. Most of the direct costs of COPD are for treating exacerbations or those patients with severe COPD. The major costs include medications, hospital or urgent care visits, and outpatient visits. The sources of these costs underscores several things. First of all, it's very important to prevent initial tobacco use, so most of COPD is preventable. Secondly, preventing disease progression with early tobacco cessation. So tobacco cessation remains the only intervention at this time to potentially slow COPD progression. In terms of preventing exacerbations, one important method is by encouraging vaccinations. And lastly, it's important that we find more effective therapies for preventing exacerbations. As will be discussed, the current therapies that we have available have only a very modest impact on decreasing the frequency and severity of exacerbations. Indirect costs of COPD are much harder to measure, but the estimated costs appear to be approaching that of direct costs. In addition to missed work or lower productivity of the patient, one should also consider other costs, such as early retirement due to COPD and its disability, decreased activity levels.